So let's get started. Right now I'm remembering a warning that our guests offered at the end of our last webinar, which focused on the Delta variant. Some of you may remember this, but near the end we asked, how can theaters survive if COVID continues to mutate and becomes resistant to our current vaccines? And Dr. Murphy shared a very clear warning, which was amplified by Dr. Sanchez, that if we kept giving the virus time to roll the dice, it would mutate into something even more contagious. Here we are 4 months later. But 4 months later, we now have even more experience with mitigation strategies that we know have allowed many of you to move forward with a lot of heart and care for your audiences, for your people, and to help us to continue to move forward in that spirit of care. We are once again joined by two extraordinary public health leaders, Dr. Robert L. Murphy, the Executive Director at the Institute for Global Health, and John Philip Phair, Professor of Infectious Diseases at the Feinberg School of Medicine, and Dr. Eduardo Sanchez, the Chief Medical Officer for Prevention at the American Heart Association, and also a board member of Dallas Summer Musicals. So thank you both for letting us get the band back together and for being here with us again. So what we're going to do is we'll do some introductions. First, Eduardo, and then Rob. And Rob is going to share some very hot off the presses information with a few slides. And then we're going to move into the questions that you have sent me. Thank you for doing that. So we'll begin with Eduardo. Please introduce yourself.
Hi, everybody. Eduardo Sanchez. As Corinna said, I serve as the Chief Medical Officer for Prevention at the American Heart Association. We're headquartered and I lived in Dallas, Texas, land of the Kickapoo, but the blood that courses through my body is 100% blood from the Dominican Republic, land of the Taino Indians. It's really an honor to be with y'all. Yeah, I'm on the board of Dallas Summer Musicals. I'm actually going to Hadestown tomorrow. All our events are fully masked. The expectation is and the encouragement is that everyone is vaccinated. But I do live in the land of Dallas, where, oh my gosh, wearing a mask is not as widely practiced as I wish it were. I did get to spend the part of the holiday from December 26th to December 7th in Spain. And there were a couple of things about Spain that I found to be quite interesting. One, everyone wears a mask. Inside and outside, people wear masks. Masks come off in restaurants. That was a little scary at times, but again, people are very mindful of having those masks on when they're walking around. The other thing that was that I observed was that you could walk into any pharmacy and walk out with plenty of home tests, and so it felt safe to me. And as a public health guy, those are the things that I look out for. In the midst of Omicron last week, I did 18 interviews in Spanish about the Omicron variant. The common question I'm asked is, what's the number one thing I can do? And I said, let me tell you 3 things that you can do. One is, if you're not vaccinated, get vaccinated and get boosted. Get on that, get on the treadmill to get that stuff done as quickly as possible. Wear a mask, ideally an N95 or KN95 mask. Do what you can to make sure you're getting a real one. But the other thing I said is, a mask is better than no mask, period. A mask is better than no mask, but some masks are better than others. And lastly, use your judgment around social distancing. And if you're around lots of people, even outside, put a mask on. They're going to protect you. You have to do your best to know whether it's real or not. I'm not sure that I know the best way to know that it's real, but as I said, a mask is better than no mask. So I'm going to stop there and leave the rest of it to the last thing I'll say is, predictions are folly. And anyone who can tell you that they know what's going to happen tomorrow or next week or with the next variant needs to remember that just about 3 months ago, there were people who were doing that. And the idea that we could know now what's happening with this pandemic based on the pandemic that took place in 1918 would be a little bit like asking Dr. Murphy or myself to tell you what's going to happen with one individual patient based on looking at one other individual patient. There's just not a thing that people do. And so I'll just stop there. And Rob, if you think I'm off base, it's okay to say I disagree, because friendly disagreement is always a good thing. But looking forward to your comments, and then looking forward to trying to answer questions in a way that provides you some comfort, and that you can make some smart decisions, protect yourself, protect those you love, and begin to make a difference in terms of the work that you do and the work that you're interested in keeping alive in the United States. So I'll stop there. Rob, over to you.
Great. Well, thanks again for inviting me back. I'm glad I made the right prediction last time. We both did. But anyway, I'm trained in infectious diseases and epidemiology. So this is my area. And I'm going to make a prediction. And I've studied pandemics pretty extensively. All pandemics end. Every single pandemic over history, and there's been many, they all come to an end. The question is, how much damage occurs, how much death and disability and sickness occurs before it ends. That's really the only thing. So I'm going to start with just a couple of slides that update where we are with the pandemic, specifically with Omicron. And this is a snapshot from today from the Johns Hopkins website about what's happening in the world. And I think we have to keep a global perspective because it's a global disease. You can't just take care of your city, your state, or your country. This virus is going everywhere. But there's over 5 million deaths, 343 million cases, and interestingly, almost 10 billion doses of vaccine have been given out worldwide. Now, there's some 20 vaccines that are out there. Some work better than others, but it's really phenomenal that we've gotten up. It's like 5 billion more than the last time I was here. So people are getting vaccinated like crazy. This is now data from the United States. Sadly, we are number one in number of cases and number one in the number of deaths. And we've had 861,000 deaths, 69 million cases. And we, in this country alone, with just 3 different vaccines, have given out 529 million doses, all right? Now, the little curve on the right, those little graphs on the right, those are the weekly case numbers. You can see what Omicron has done since we met last time. It's now the biggest spike of all. This is in the whole pandemic. If you look at the death rate is the middle one in the white. It's flattened out and it's not as high as it was before. And that's because the treatments have gotten much better. And then this is the weekly the green part at the bottom is the weekly doses administered for vaccines. And you can see that's kind of flat. And that's a little bit disturbing. These are just the daily cases, just to illustrate it a little better. You can see at the tip of this peak that it does look like it's going down. If you look back to December 2020, there was also a peak there in the daily number of cases. And it started exactly at the same time as this current peak. It was the Christmas, New Year's holiday, winter holiday period where people met, came back, got infected, started getting hospitalized a couple weeks later. And it's the exact same thing. So this is going to be a seasonal phenomenon with this particular disease. We had, of course, the peak with Delta, the little bump that you see around September of last year, just with the last time we met, and that's from Delta. But the epidemic right now is Omicron plus it's the actual season. Now this is hospitalizations. I think very soon we're not going to be reporting the number of cases anymore. Too many people are getting diagnosed at home with the home test. They don't even count in any of these numbers, by the way. And it's very hard to keep up with the counting. However, hospitals have to report this. So they're required to report, and we now have more people hospitalized than ever. 80 to 90% of the people in the hospital are unvaccinated. 95 to 97% in the ICU, which is the dark blue on the bottom, are unvaccinated. And if you look at individuals over 50, because age is a risk factor, you're 45 times more likely to be hospitalized if you're unvaccinated compared to if you're vaccinated in that particular age group. So you take the highest risk group and you look at it vaccinated versus not vaccinated. Now, I'm head of global health at Northwestern University. So I'm looking at this worldwide. And this is data from South Africa and their hospitalization rate for the peaks that they had. And they have incredibly homogeneous peaks. You can see the three big peaks. Ours were kind of all over the place, but the United States is such a big country, and different parts of the country. Texas acts different from New York and Illinois and California, and Florida, everybody's different. But I want you to point out actually something that's good. I want to give some hope here. The peak at the end, to your far right, is the Omicron peak. First of all, their peak in hospitalizations is not as high as the other one, unlike us. They have a younger population. There's a bunch of reasons for this, but look how narrow that peak is. The other peaks are all like measured in months. The Omicron peak is actually measured in weeks to maybe 1 or 2 months. And we're starting to see the same thing here. But again, we have a big country. It's like we're multiple countries, but that's a very promising thing. We're fast up, and it's going to be fast down. You're going to see a very different picture in the next 30 days in this country. This is the death rate. The death rate is always the last metric. It's very easy to measure. It's hard to determine if it's actually 100% from COVID or COVID was just there when they died. There's a bunch of problems with measuring just death rate, but it's flat now. And this will be the last thing actually to improve. Now here's the vaccination data in the United States. We're ranked among high-income countries. There's only a couple other countries that are worse than us in terms of death rate. And they're relatively small countries like Hungary, Slovakia, and the Czech Republic. Otherwise, then we come in fourth. And of course, we're more than 10 times bigger than those countries combined. But anyhow, these are the number of people who've gotten the vaccination here. 531 million doses have been given, and 209 million people have been fully vaccinated. Unfortunately, only 40% of them have received a booster dose, and the booster actually makes a big difference. So it gives our overall proportion of the population that's vaccinated is 63%, but remember, kids under 5 aren't eligible to take it. And if you look at over 65, it's almost 90%. And that's what we're seeing now in Europe in all the age groups that are eligible to take the vaccine. They have less kids vaccinated. They approved the kid thing later than we did. But their populations, like in France and Spain, Germany, it's close to 90%. And the reason for that is not so much they really want the vaccines, although they tend to accept them better than we do, but the mandates are really strong there. Like you can't even get a cup of coffee at a cafe in France. I don't know how it was when you were in Spain, Eduardo, but you've got to be vaccinated, and you have a card. Everybody has an app and whatever. Here's data. This is just from Chicago, but this is representative of what's happening everywhere between the unvaccinated and the vaccinated in terms of hospitalization. And you can see there's even a difference between vaccinated with the 2 doses and vaccinated with the booster. There's a statistically significant difference. So the booster really helps the vaccine. Now, vaccination, it seems pretty clear to an infectious disease doctor, a public health person. It seems like why wouldn't people look at all this data and just take the vaccine? We've got over 500 million doses given. There's been 8 billion worldwide. If there was any weird problem, we would have picked it up by now. So the Kaiser Family Foundation has done a very nice job. I highly recommend you look at their website if you want to get some really good data. But the most likely people to be vaccinated in the top red circle there are Democrats, I mean, capital D Democrats, older people, educated people, urban people, Hispanic people, and women. And the group at the bottom, starting from the least likely, are uninsured people, Republicans with a capital R, evangelicals, younger adults, and rural people. So it's in any disease I've ever looked at, there's never been a political difference in outcomes. So this is the first time where the politics has really gotten involved in the public health. So how do we stay healthy and keep our workplace healthy? Vaccinate with a booster, like Eduardo just said, and use a good mask. So there's all sorts of masks. I listed them all here. So there's the N95. This is the NIOSH, National Institute of Occupational Safety and Health. These are definitely the best, 95% protective. The KN95 is the Chinese version of that. But beware, 60% in the United States are counterfeit. You have to really be careful. The NIOSH, the N95 masks, the US ones, are actually made in China, but they're NIOSH made. NIOSH paid for them. The KF94s are the Korean version, and the FFP2 is the European version. If you don't have access to any of them, you can double surgical mask or put cloth over a surgical mask, and that works about 85% of the time. The other ones are 94, 95%. And the surgical mask by itself is 40%. And the cloth mask by itself is 20%. These are all rough estimates, but there's data to back that up. So there is a big difference. So that's why the CDC just last week actually upgraded their recommendations on the mask to get you in the upper category here. Get those KN95s or the N95s if you can handle it. If you happen to have an underlying immunocompromised disease, you can take a drug called Evusheld. It's an injection monoclonal antibody made by AstraZeneca. 2 shots at one time. It lasts for 6 months and it works against Omicron. So people who have underlying cancer, organ transplants, severe immunodeficiency, they're eligible for that. It's hard to get it, but it's coming forward now and it is out there. And then if you do get infected, there are monoclonal antibody treatments. There's one that still works for Omicron, and there's Paxlovid and Molnupiravir, which are oral drugs that can, in the case of Paxlovid, the Pfizer drug, 90% effective keeping you out of the hospital. Molnupiravir only 30%, but still 30% is better than 0. All right. So those are the things going on. What about testing? There's a lot of questions about testing. There's 2 big categories, molecular and antigen tests. The molecular are the PCR tests, the LAMP test, the isothermal molecular test. It's really the best for diagnosis, but it's typically slow and it's more expensive. Now, there are some fast LAMP and PCR tests coming forward, but they're almost here. Literally in the next 30 days, 2 of them are going to get approved. The antigen tests are these rapid tests, the over-the-counter tests, the Binax now, the Quick View. They're very rapid. They are not as sensitive, and they're much better if you have a symptom. If you don't have a symptom, they don't work too good. But if you have a runny nose or a sore throat or any cough or anything like that, they work good enough. And they're best also for follow-up, and they're inexpensive. The PCR tests, unfortunately, for follow-up, they can pick up just a piece of a molecule, doesn't necessarily mean it's infectious. And that's why the CDC guidance, which came out last week also, now you don't have to get out of isolation and quarantine, you don't even need a test anymore. We'll talk about that during the question period. But the summary is here. So if you're vaccinated to quarantine, you've been exposed to somebody, no longer required the quarantine unless you get a symptom. You're supposed to wear a mask for 10 days. And if you want to get out of jail early, get it tested day 5. If symptomatic, you fall into you got to go get evaluated. If you're not fully vaccinated or you're unvaccinated, you're supposed to stay home for 5 days and then return to work if you're asymptomatic, but you're supposed to wear a mask for the first 5 days when you return. So that's definitely changed from before. If you get infected, you go into what's called isolation, 5 days at home. if you're asymptomatic, you can return to work without a test if you wear a mask for another 5 days. And this is without regard to vaccine status. And the reason for this is that the virus gets out of your system really quickly. You can still be sick, especially with pneumonia, but after 10 days, it's very hard to isolate the virus. That's where the original 10 days came from. The 5 days came in because so many people were out of work. I mean, the military, the hospitals, the airlines, I mean, they were having trouble functioning because so many people were out, because that spike in the Omicron was so steep. Mandates for vaccines, the Supreme Court just knocked down 2 of them. The federal government employees, that's knocked down. They don't have to take it anymore. And the companies with over 100 people also was kicked out. However, the states can mandate, and your company, your theater company, can mandate vaccines, and that's totally legal, and that's all been held up in the courts. But mandates are nothing new with vaccines. It started in 1777. George Washington mandated that the Continental Army get vaccinated because too many people were getting smallpox. And this was upheld twice in the courts, in the Supreme Court, back in the 19th and early 20th century. And it's been held up even more recently now for COVID. So if you, one final thing on risk summary, there's always a risk. There's a risk to anything that we recommend or do. COVID vaccines, the risk of death per million events is 18. And that's compared to all vaccines, which is 44. That's twice as much with the vaccines that you take anyway. And twice as much of that is homicides. And almost twice as much of that is getting shot. And another 25% or similar to that is car accidents and suicides. And twice as much as that is drug overdoses. And then alcohol. And then twice as much of that is injuries. And 3 times as much of that is smoking. And then 12 times as much of that is actually getting COVID. COVID is a lethal disease. And there's all sorts of long-acting things that can happen later that, COVID is much worse than getting the vaccine. So that is the end, and we can take the questions now.
Thank you both so much for sharing your perspectives on where we are in this moment. It was nice to hear some notes of hope and also some clarity around, what we can expect in the weeks to come. So we did want to drill down a little bit more into testing protocols. And I think that what we're looking for here is not just the CDC recommendations, although that was very helpful to be reminded that those have been updated and they exist, but also to hear from the two of you, what you really think can ensure the safety and wellness of the staff of theaters and the audiences. So for example, some of the questions that we have are related to, at what point is someone no longer contagious, considering both the CDC recommendations and your own experiences?
You got to direct the question to either one of us, or
yeah, let's hear from Eduardo first, and then we'll go to you, Rob.
Eduardo, you're
as a good family physician who knows when to say, I don't know the answer to that, but I'm going to find out for you. It's not that I don't know the answer. I mean, I think Rob spoke to that. 10 days seems to be the demarcation. Wearing a mask seems to be one of the ways that you assure that in a period of time where perhaps you may not be contagious, you absolutely cover for that that period. But I'm going to defer. My sense is 10 days. But the other thing I'm hearing is, if people are wearing masks, you reduce the likelihood of transmission pretty dramatically when 2 people are wearing masks as opposed to only 1 person wearing a mask. So Rob, over to you.
Exactly. I don't have anything to add to that. We've done the data and people vaccinated and unvaccinated, and after 10 days, it's very hard to find viable virus, actual virus. So 10 days is the longest, and the average is about 5 to 7. But the virus is actually, the level is coming down pretty steep during that time. And the way they count it is day 0 is the first day of your symptoms. okay? If you're asymptomatic and your PCR test is positive, it's the day of the test. So it's not day one, it's day 0. And then you count out, to 5 or to 10, depending on what are the metrics you're going to use to get back to work.
Thank you both for that. Another thing that people wanted to hear about is, there are protocols that have theaters testing 3 times a week. Does that feel appropriate for you? Should it be more? Should it be less? And how should it evolve as the virus evolves?
I'm going to defer to Rob on this one.
Yeah. You have to tailor this to your business, to your profession. You people work very closely together, shouting, singing, all sorts of highly infectious things. So I think some kind of routine testing is warranted. Now, remember, if you're asymptomatic, those rapid tests are not that good. All right. So there are some molecular tests you can do that are faster. And, if you're asymptomatic and you're vaccinated, the level goes down even more. And the other important thing here is you have to look at where you are in the pandemic. And every city is different now. But you saw that curve going down. So you look at the number of cases per 100,000 people. It's a little bit nerdy, but you want to be at the 5 to 10 cases per 100,000 population. That's low. That's a low risk period. You probably don't, maybe you only have to test once a week in a situation like that. However, we are in Chicago, it's 140 per 100,000, and the state of Illinois is like 230, and the United States is like 250, and then some of the states are like in the 500s, like Wyoming and stuff. So it really all depends where you are in that number. So they tried to make it easy, but it made it more complicated. It's color coded, red, orange, yellow, green. So right now everybody is red basically. So the whole country is like out of control. But it's steeply going down, and you're going to see people to go into those other zones. And so you can tailor and it's very difficult to write a policy for this because, in some places, the risk is going to be very low and it'll be much safer to work together, and you don't have to be so onerous with your testing. But, those are the factors that go in to how much testing you're going to be. I think because the way you work, you have to be doing some kind of routine testing. I look at it like what we did with the college students. We tested everybody, and then during the trough periods after the peak was over, it was like we were doing thousands of tests and like nobody was positive. Now they're all positive. Or not all, but lots.
So I'll add a couple of things. One is, I think what Rob is saying is this is all situational, and you have to be aware of what the situation is. And I think I'm also hearing Rob say, fortunately, most of the folks on this particular call are in one community, and all you have to figure out is what's going on in one community. But Rob's point is well taken. I work for the American Heart Association. We have a national footprint, and we've been struggling to figure out how do you, on the one hand, have some nuance, but at the same time, have some standardization. But situational awareness is really, really important. I think the other thing is that in addition to at least encouraging, if not mandating vaccine, if it was up to me, we just mandate, but that's me. And then again, masks at the appropriate places. It's kind of the commitment on the part of team members to act in a responsible way when they're not at work. Because the other thing is that it's not, if everyone's doing the right thing at work, it's not work where you're likely getting where an infection introduces itself. It's outside of work. So we should all kind of be mindful of what it is we're doing, who we're interacting with, not in a completely obsessive compulsive way, but certainly more obsessive compulsive than we needed to be 5 years ago, because that's how this happens. If you let your guard down, so to speak, at the family reunion, where there's all kinds of families from different places coming and then go to work, all that regimentation at work kind of went by the wayside because there wasn't some degree of being mindful of things when you were outside of work. And last thing I'll say is that we had come up with a protocol for testing pre-Omicron and realized that the testing protocol probably was insufficient with such a high transmissibility variant. So I think I'm just adding a little color to some of what Rob said. Some testing regimen is important, but situational awareness is one of the critically important factors.
Eduardo, just a follow-up question there. When you were shifting over your testing regimen, or if you're in the process of shifting over your testing regimen, what was it and what is it now during Omicron?
Well, honestly, what we did was what we did shift was the expectation that people might come to work. So about 2 months ago, we toyed with the idea that we would have more people show up at work, and we were asking that folks come 1 to 2 days a week. We still have a 100% mask unless you're in your office by yourself. And we don't have a mask mandate, but we have a strong mask wish. We've actually offered incentives to folks who no, it's you either vaccinate. Originally, it was vaccinate or test. Now it's you gotta. We've just backed off and said, please don't come to work for now. So one thing I would say, the situational awareness, the preposition that we have adopted is for now. During this time of Omicron, this is how we're going to do things, because things are not what they were 2 months ago. And this is not the Delta variant. This is actually maybe not as severe, but definitely more transmissible. And I think that one of Rob's points that's important to make is that some of this issue, something you hear is, well, I can get infected. It's not a big deal. And it's not about, in my situation, I'll give you an example. It's not about me. It's about the fact that my 84-year-old mother-in-law shares space with us. That's the person that I'm worried about, not me so much. But I still have to be just as vigilant about not getting infected to protect her, as opposed to about protecting me. And I think that's another thing that we keep trying to encourage people to think. That's not just about you, it's about who you might come into contact with at that family reunion or at that dinner, and being really mindful of what you're doing. So our shift was to backtrack a little bit and say, you know what, for now, let's not encourage people to come to our physical workspace and revisit this issue when hopefully in a few weeks, agree with Rob, it's weeks, not months this time around, we can begin thinking about how to put our toe in the water again.
Thank you for that. So this next question I think is pretty straightforward, which is for Rob. Can we have a copy of your presentation sent to the participants?
Sure.
Thank you. The next question may also be straightforward based on some of the things that the two of you have already shared, but it has to do with this 10-day marker. Even if someone who has tested positive is at their 10-day marker, even if they still have active symptoms, it's still okay for them to come out of quarantine, or no?
No.
Okay.
No. Active symptoms, no. Now, some people, if they've lost their sense of smell, that can last for months. So, but if they've stopped coughing and have no fever and feel much better, they can go back. It's a little bit vague in the guideline, and they did that on purpose, but you have to be remarkably better and not have a fever.
Thank you for that.
Yeah, and so Corinna, and I think the opposite of that is you don't need to, if you are having symptoms and can't get a test, for God's sake, stay home.
Just stay home.
One of the messages here is that it doesn't just have to be, and oh, by the way, one other thing that I think Rob and I might have said last time, we'll say it again, it's still not too late to go get an influenza vaccine, go get one.
Thank you for that. Well, keeping going on this like question of symptoms, because we do have a kind of detailed question about it, which is that people were using language that I think that they borrowed from a school district as part of their daily check-ins that prioritized certain kinds of symptoms called Class A symptoms as being a highly likely indicator of a COVID-19 case, and those being fever, chills, new loss of taste or smell, and Class B symptoms, which were the more likely to be attributed to a common cold, including fatigue, headache, sore throat. Their concern was that these Class A, Class B symptoms were no longer accurate, given that Omicron manifests differently. What is your take on how Omicron is manifesting symptomatically, and should those like guidelines change?
Omicron presents more as an upper respiratory infection, so it's more like a cold, more like a flu. It's less lower, although it can end up with pneumonia, and it is less deadly, but maybe only by as much as 25%, 50%. We thought it was actually a lot less, had less severe disease, but it turns out that's actually not the case in the United States. It's not, it is less, but not as much. You don't want to get it. But yeah, all these symptoms that you have on here, you know, if you have any of them, you have to get tested.
Thank you for that.
A or B, doesn't make any difference.
Very good. Thank you. So just noting to the people who are asking great questions in the chat, I'm going to try to work those in while also trying to work through the questions that were submitted earlier. Hopefully we'll get through them all. I think we can. So now moving into these questions of audience safety, you know, in terms of requiring, mandating masks, mandating vaccination, do you feel that theaters should be mandating now proof of a booster shot as well? Should they be mandating medical grade masks? Should that be a part of the expectation of coming into a theater space as an audience member?
I think the mandates, I think you're going to be lucky just to get what they call fully vaccinated, which is the first 2 shots or the 1 shot of the J&J. I mean, there's so many people that are not boosted yet. I think it's just going to be on a practical level very difficult to do right now. It would certainly be better, especially with Omicron. You have a difference between 57 and 90% of efficacy with Omicron of keeping you out of the hospital. But I think as far as a theater is concerned, you know, you're doing more than one thing. So you're doing the vaccines, certainly 2 vaccines. You're doing the masks. I don't know if you're spreading people out more or anything else. I don't know if you've done anything with your ventilation of your buildings. But you know, all that comes into play. It's not just one thing. So I think it would behoove you, and you'd save some of your audience, if you just upgraded the masks. And the upgrade is as simple as if they come with 1 cloth mask or 1 little blue surgical mask, just give them a second one to put on top of it. That gets you up to 85% efficacy from 40% or 20% for a cloth mask. So something simple like that is a lot more palatable from a public health standpoint.
So we're grappling with this because we, the American Heart Association, do events, and we do them across the country. So if we're doing an event in San Francisco or New York, the culture is different than doing an event in Birmingham or Dallas, frankly, and we're trying to sort our way through that. So one of the things that we're doing, and I think this is worthwhile, we are talking and pointing to the science that says you are best protected and you protect other folks when you're boosted. And so whether we're going to mandate it or not, it'd be a real good idea to get boosted if you care about things. The one thing we also believe, we'd like to believe, and maybe all of us, is that people that go to theaters are maybe different than people who go to X, Y, or Z. Won't say anything. That may not be true, but we sometimes when you hold people to expectations, they will respond accordingly. So we also are talking about, please bring a mask. An N95 or KN95 mask is preferred. That's the kind of language we're using, and to the point that Rob's making, if they're wearing a cloth mask, we should hand them ones that we have back in reserve. We are in this time of Omicron for some of our events, requesting testing. And 24 hours in advance or at the day before. We're using the same criteria that the federal government is using. The day before, we in those events, and we're not talking about thousands of people, we're talking about hundreds of people, but we also are talking about, we haven't done this quite yet, having home test capability on site. Would agree with Rob, definitely not the gold standard, but when you stack up all these different things, it buys you a level of protection. Last thing, I saw a question in there about what do you do about eating and drinking? I do think you, again, tell people, do it for a short period, have your mask unless you're eating or drinking, stay away from folks that you don't know, have some social distancing. You can't tell people not to drink if they're going to be somewhere for 2 hours, not, because water might be a thing that's a healthy thing to do. We did create these visuals. I'm not going to try to share it because I'm not smart enough to do that. Dip, sip, and equip. Dip your mask, sip your drink, put the mask back on. It's a visual. We prepared those at AHA, and Ken Wisdom at Dallas Summer Musicals actually has borrowed those, and we're using them in the Dallas Summer Musicals venues. Again, everything that somebody does that reduces time of exposure, the likelihood of transmissibility, when you add all of that stuff up together, it equals more protection than not. And we can't guarantee 100%, but you can try to reduce risk as much as possible. And we're pretty comfortable, at least at Dallas Summer Musicals and at AHA, doing the things the way I've described them. I think they align with what Rob is saying.
Thank you both. So there are two big buckets of conversation that I want to make sure we do get to before we're done. And the first is vaccine communication. And the second is, from pandemic to endemic. And so the first one you've already been kind of talking about, which is how you communicate the importance of vaccination, particularly to communities who have been marginalized by the medical industry. How do you have that conversation in a way that isn't further reinforcing that feeling of exclusivity or harm? And yeah, if the two of you could speak to that, that'd be helpful. What have you found useful in terms of communication?
Yeah, I think, I was really shocked when I saw that Kaiser Family Foundation data on who's least likely to get a vaccine and most likely. In the top group is Hispanic ethnicity. And that had been a group that had usually not been, had been avoiding a lot of medical stuff. And African Americans actually don't fall in either one of those groups, the high or the low. They're in the middle. So I think there's been tremendous movement in those communities. And basically what the programs that are out there to reach underserved populations apparently have been quite successful. We're having a lot of trouble with Republicans, so I don't know what to do about that. But so I think we can get over that. But it's not going to be an older white guy telling them that it's okay to take the vaccine. All right. I could talk till I'm blue in the face or show them chart after chart. It's not going to work. So you have to find the people that they respect. And if you look at the Kaiser group has already done this, almost every group respects their pediatrician and their family doctor. Those are in the high 80%. So, let's start there and get the communication rolling where the people have some respect.
So I'll just add to that and say, and my background is in public health, and trying to get figured out how you deal with these thorny challenges. One thing, and I'm going to underscore what Rob said, it is a myth that Black people and Latino people don't ... What is not a myth is that if you don't think about the delivery, then you will miss an opportunity to actually debunk those myths. So messengers matter. And the point that Rob was making, Rob Murphy cannot be the guy who gets in front of a group of whatever and thinks he's going to convince them. And it may not be Eduardo Sanchez either, but it might be. So messenger matters. Message matters as well. So you can't talk to people as if you're smarter than they are, or you think you're smarter than they are. You got to talk to people at the level that they understand what it is that you're trying to convey. And some folks are good at doing that. And sometimes the smartest guy is not the one to be the messenger because they don't message very well. And the third is that meeting people where they are matters. And that's not just about the messenger and the message, but the medium, not only of the messaging, but the medium of the delivery of the thing. So Dallas did these mass vaccination sites. Well, if you live in a community that's 10 miles away and don't have a car and don't have an internet connection to make an appointment, you are not going to get vaccinated. So meeting people where they are also means understanding some nuance and delivering message and medicine, if you will, to folks with the right messenger and the right message. So I'm repeating everything that Rob said. And I think that I would say to those of y'all who are here, partner with some of the community-based organizations in your communities that are serving different segments of the population, be that by race, ethnicity, be that by gender identity, be that by professional association. And as for Republicans, I don't know what the answer is there. That one's just kind of crazy. I take that back because I'm trying to learn not to use that word. That's just kind of hard to understand. And I'm trying to be really mindful about not using trigger words, but acknowledging when I use them, pull them back and replace the word with one that should be used. So it's hard for me to understand that. And oh, by the way, like, what more proof do you need that there is a 50 times higher likelihood that you're going to end up in the hospital if you get infected than if you are vaccinated and get it? Like, what, when someone says, I need more proof, what more proof can there be? If you jump off the cliff, you're going to break your bones. And if you don't, you're not. And people are still jumping off the cliff. Makes no sense to me.
So in the limited time we have left, there are two questions that I want to make sure we have time for. And the first has to do with, so maybe like one of you could take one and one of you can take the other. So the first question is, and I'll give them both. So the first question has to do with, in terms of the vaccine rollout and messaging and communication. Disabled and immunocompromised people have felt that ableism has been really present in who gets prioritized, who gets even acknowledged in this work. What can theaters do as they are trying to open up to make sure that these folks who are already excluded aren't further excluded by their policies around COVID mitigation? That's that one. And then the second one, as we move into a potential future where this is endemic, how can theaters plan? So for example, winter spikes, we've had 2 of them, but winter is also a season when theaters tend to be doing a lot of work, a lot of very important work that they depend on. So how can we plan around an endemic COVID-19?
Both easy questions. So I'll defer. You take one of the easy ones and I'll take the other one of the easy ones.
Okay, you go first.
Oh, Lord, like you just said, that didn't work. Okay, you know what? I'll do the one about ableism. And I would say that my sense is that theater organizations and theater groups are very, very aware of their communities. And so it seems to me there's a couple of things to try to do. One is to partner with organizations that are serving the population, whether it's immunocompromised folks and or folks with disabilities, and say, how can we partner to not only get information, but try to identify ways to get vaccine, if that's the issue, into people's arms, because and that's if they want them. But our sense is, and I think that what has been demonstrated by this Kaiser Family Foundation thing, is that this myth that people don't want things has not been tested by offering them the opportunity. And when offered the opportunity, people are taking vaccine and using masks more than not. There's a too high of a percentage that is. And then the other is being the connector for those folks themselves, and offering yourselves up as the connector with organizations that might be able to deliver vaccines to people. You could, if you were comfortable with the idea of testing, you could also offer, that the day before or day of testing. It's not the best, but again, it gets to offering an opportunity for people who seem to feel left out to be able to participate. So it's going to take a little bit of work, but I'm hearing in that question the desire to do a little bit of that exploration. I hope that helped.
Yeah, that was helpful. And I think that this is an area of learning for me too. But I think that there are immunocompromised people for whom the vaccine may not work as well. And so there's this question of, as theaters are reopening, we've done a lot of digital programming that has been more accessible than our in-person programming. And that may be one way to stay connected to a community that may still not be safe in our theaters. But because we're so short on time, I want to make sure we hear from Rob about pandemic to endemic.
Yeah, I think that's what's happening right now, actually. I think this is the beginning of the transition. I hope I'm right. I mean, all pandemics end. And I think what will happen is we're going to learn from Israel, France, and the other high vaccinated countries, and the United Kingdom for different reasons. But those three countries have in common is a very high vaccination rate and a very high immunity rate. In other words, they've got evidence of not only the vaccine, but being infected, particularly the United Kingdom. So they predict right now, the Imperial College London, who are one of the greatest epidemiologists in the world, that 95% of the UK citizens within the next 30 days will have immunity to coronavirus. Now, whether it's good enough or whatever, but they're going to have some immunity. They're going to have a lot of immunity. In France, they're already over 90% vaccinated. In Denmark, other countries like that. And Israel was the first one out the door. So we're going to be able to see kind of what happens there. And everyone's happy to roll back on these mitigations, believe me. But they can't go too quickly. We went too quick as soon as Delta looked like it was getting under control, and look what happened. We really, the schools starting in January, I think was one of the, it'll be written as one of the biggest disasters that ever happened. And when I spoke out about the school issue, I was crucified. I mean, I was like, wow, I don't know if I want to keep this job. I got a day job. I'm going to just stop that. But anyway, I think, so we have to be careful in how it comes back, but we're going to have that vision. And you're going to see, maybe there'll be other waves. Hopefully they're going to be less, and we're going to know what to do right away. We're going to have Paxlovid. We're going to have molnupiravir. We're going to have other drugs. We're going to have ramp up in these antibodies that are going to be present. We're going to have a version 2 vaccine. We're going to have a lot more testing available. I mean, it's, we got overwhelmed with Omicron, but there's going to be we're going to be flooded. The market will be flooded with these tests, including molecular tests, which are much better. So I think everything in those toolboxes as we go forward, I think we'll be able to control the current epidemic, the current pandemic where we are now, as it transitions to an endemic and even different variants. Because I think now we got 2 years later, we're getting the immunity that we need, and we have the tools to do it. And we can get back to normal.
Ooh. Even
Well, and I also think we're not going to go back to the way we were.
exactly. Thank you both so much. Let's please give some love for Dr. Murphy and Dr. Sanchez in the chat. Show them appreciation. I also want to thank my colleague Anne, who's been stage managing our Zoom play today. A few very quick last things before we go. We've got a survey for you. We hope you'll fill it out. It actually does help us improve our work. And finally, this webinar and so much of TCG's programming over the last 22 months has been free. We do kindly ask for your support. So feel free to use the tcg.org/donate link, which Anne will put in the chat. It helps us support these webinars, TCG Books, American Theater Magazine, all of our convenings, our EDI work, federal arts advocacy. Please give if you can. Until then, just offering another huge note of thanks to Rob and Eduardo for helping us through this. I hope you all have restful weekends, and we will see you soon.